everybody. Welcome. Thank you for joining us. We're just going to give it another awkward minute or two for participants to straggle in, attendees to straggle in, and then we'll get going, and I'm sure people can catch up. But it's wonderful to see so many names filling the attendee panel, folks we know, folks we don't know, but excited to get to know down the road. So thanks for joining us. Let's just go ahead and get started. People can catch up, right? So welcome. Thank you so much for joining us today. I'm Jessica Shortall. I'm the strategic partnerships lead at R Street's Healthier Communities team. And we're super excited to be co-hosting this session with National Harm Reduction Coalition. Unfortunately, NHRC's Gabby Zavala Aleman, the Tobacco Harm Reduction Education and Engagement Project Manager at NHRC, was unable to join us due to illness. So we're wishing Gabby swift recovery. And that means you all are stuck with me for the next hour. So I'm also going to just warn everyone up front. I'm in Minnesota. We have had a horrible wildfire smoke. If I disappear for a second, it's because I'm having a hideous coughing fit, and I'll be right back. And I trust our panelists to just soldier on without me while I get myself back together. So to set the stage, and then we're going to get into intros and I'll talk a lot less. Here's the reality that we're facing and why we're here today. Smoking kills almost 500,000 Americans a year. And our ultimate shared goal here, and I assume many of the folks participating, attending today, is to find ways to reduce that burden of disease and death. And that means helping more people quit smoking, especially in the communities where smoking remains stubbornly high, because we have this wonderful success story where adult smoking in the US is below 10% for the first time ever. But in some communities, that's just not true. It's very high. So I'm going to drop links in the chat to our past two events in this series, this summer series, where we've heard from experts and people with lived experience about two of the communities where smoking rates remain very high. So people with HIV and people who use drugs. And obviously there's some overlap in those communities. All right. So why talk about tobacco harm reduction as part of this picture? And by that, we mean switching from smoking to a less risky form of nicotine use. Why not just tell people to quit using the available methods out there, like medications and nicotine replacement and behavioral therapy? Those are all a very important part of the picture, and they do help some people quit. But if they were perfectly effective for everyone, we would not see millions of people left behind and continuing to smoke, especially in these already vulnerable communities. So taking a page from the world of opioid use, that's exactly where harm reduction can be an important added tool and approach. So today we want to zoom out. We're going to talk about why the conversation about tobacco harm reduction has such a hard time reaching people, reaching the public, reaching healthcare practitioners who could benefit from learning about it as one of many cessation options. So, okay, first a quick introduction to our panelists. By the way, I learned the one day of very bad air we had here was equivalent to about me smoking about a half pack of cigarettes. So I'm really
I was
feeling
going
it.
to say your commitment to walking the talk of the harmfulness of inhaling smoke, Jessica, is deserves praise.
We're here to serve.
And hopefully you don't suffer too much from it.
We're here to serve. Yeah, I've got a lot of empathy for that right this minute. Okay, so we've got Jeffrey Willett, director of the Project to End Smoking at the Progressive Policy Institute, or PPI. Jeff has a long history in public health and health philanthropy. Helen Redmond, senior editor and multimedia journalist at Filter Magazine and adjunct assistant professor at NYU. And Helen's been advocating for tobacco harm reduction and harm reduction in drug use and harm reduction generally for a long time, including reporting, writing. She's got a new book on methadone called Liquid Handcuffs, as well as leading groups of people in the real world who use drugs and are swapping cigarettes out for vapes. And Joe Gitchell is CEO of Pinney Associates, and he's had a front row seat to the emergence of reduced harm nicotine products and the intense backlash against them. Okay, so that's all the intros. Welcome. If I missed anything, jump over me and say, okay, we're going to keep going. All right, so let's talk. We're going to talk about the big disconnect. I would love to hear what you all have seen and experienced from big trusted national health organizations, from public health leaders, when it comes to talking about including harm reduction tools for smoking cessation, things like vapes, e-cigarettes, nicotine pouches in that smoking cessation picture. What are the folks that many Americans trust and healthcare practitioners trust saying, and how does that fit with the evidence? So let's go to Helen first.
Okay, well, big organizations, right? Public health organizations, the CDC, NIDA. I think what they're saying has not changed much over time from what when I look at these websites or hear people quoted, and they're still very much in the victim's villain narrative, and that is big tobacco is behind safer nicotine products. So we see that a lot. We're still seeing a tremendous amount of misinformation. I was on the CDC website this morning, and they say it's not safe to use any kind of vape. And many of these websites even say things like the FDA hasn't approved any of these products. And so they've authorized 40 plus products, the FDA has, but they don't mention that. So my sense of the federal government and the agencies that are charged with public health are pretty much stuck in the same place that they have been for a long time. Now, I've seen a little bit of movement because sometimes they will say things like, well, if nothing else works, you can try a vape, right? It would be the last thing a person would try, or a nicotine pouch. Um, so if you've tried everything else, you can try that, but don't even use that for very long, because the other big theme here in all of these agencies, and hopefully my co-panelists will elaborate on this more, they're really wedded to abstinence. They don't want people to use nicotine. And if you do use nicotine, they want you to go towards abstinence. And that's a real problem, especially for the folks that I work with. People who use drugs, as Jessica said, people who are unhoused, people with mental health issues, and many of them will want to maintain. And so nobody can reckon with that. And I hate to be such a downer, but I don't think, or let me put it this way, we haven't made as much progress as we need to.
I see Jeff and Joe nodding heads. Jeff, you're off mute. What do you think?
Yeah, well, first, thanks to everyone for joining us today. And yeah, I'd just like to start by quickly speaking to public health's focus on smoking cessation itself. Having worked in the field of tobacco control for many years, I believe, tobacco control is largely satisfied with its own preferred smoking cessation approaches and sees little need to open the door to reduction. I think this is clear when you look at statements from the American Lung Association, which has said many times that everyone, like bold, underlined, everyone who uses tobacco products can quit using methods that are safe and effective as authorized by the FDA and through group and telephone counseling. And that's simply untrue. There are 25 million American adults who smoke cigarettes today. Most of them want to quit. Most of them have tried to quit in the past, and half of them will try to quit over the next year. And less than 1 in 10 of them will succeed using the type of methods that are approved by the American Lung Association and the major tobacco control groups in the U.S. So I believe they're comfortable and feel that those are satisfactory approaches. And the concept of harm reduction itself is a threat to the field. Tobacco control is focused. It has multiple goals, youth prevention being a key goal, and smoking cessation, protection from secondhand smoke, two of the other big goals. But for both its focus on youth prevention as well as its focus on denormalizing tobacco products in the tobacco industry, harm reduction is threatening because it is introducing new products to the market. These are, products that are authorized lower risk products by the FDA, and obviously continues to allow industry to develop and innovate new products. So harm reduction is an imminent threat or an inherent threat to tobacco control for its overall goals. And smoking cessation, quite honestly, from my experience, is very much a secondary goal for tobacco control, and one for which harm reduction can't be allowed to undermine its focus on kids in the industry.
And one of the elephants in the room, of course, is like youth prevention is very important.
Mhm.
I have two teenagers, and we have a lot of conversations about all kinds of substance use, drugs, alcohol, nicotine, tobacco, the whole gamut of things. I definitely take a pragmatic approach to those conversations because teenagers are teenagers, but like, would I love them to not start doing any of those things while they're this young? Sure, yes. And or hoping that that's what will happen, but trying to equip them with tools should they, don't drive drunk, etc. So we have those conversations at my house. So youth prevention matters a lot. I think, we're supportive of raising the age to 21 for tobacco nicotine sales for sure, and I think it's had a huge impact. Um, but to your point, Jeff, that tobacco control community with that youth prevention goal, um, tobacco harm reduction products have been heavily tied to that goal, right? As a threat, as a direct threat to that goal. Can all any of y'all?
Yeah.
We could have an entire hour just on that, but
You-
would love to hear your thoughts there.
I mean, we could, and I think the broader public health community needs to recognize that we can walk and chew gum at the same time. I don't know the extent to which tobacco control, the mainstream groups will ever recognize that, but we can protect kids, we can reduce and minimize youth nicotine use, and we can dramatically accelerate smoking cessation by implementing a broad range of strategies, those that are preferred by tobacco control and harm reduction strategies for adults who want to quit smoking and have been unable to quit through other means. And all you have to do is look at rates of youth tobacco use in the United States to see that. Youth cigarette smoking is around 1.5%. Youth nicotine pouch use is less than 2%. The rate of youth e-cigarette use has been cut by 80% over the last several years. Sometimes things actually work, and the youth prevention strategies that have been implemented by a broad range of organizations in the United States are clearly working. And there are 25 million American adults who continue to smoke cigarettes, whose lives are dramatically impacted by foreseeable premature death and disease from cigarette smoking. So that's, we got to walk and chew gum at the same time.
Yeah, absolutely. All right, Joe, what do you think?
So one, I'm really glad to join this discussion, and I would second and third Helen and Jeff's points. I won't go try to find it, but to your point about ways to communicate to like adolescents, teens in your life, I think Helen had done a piece for Filter a few years ago that was like, what should young people know about vaping if memory serves? And I remember it's the kind of direct communication that is probably more likely to be effective. So I think we're still in the midst of a clash of understandings of available evidence. And unfortunately, we're not converging on truths that allow people to cohere and then agree on what would be good policy. What are we trying to accomplish here? And so much of that stems from embracing the fact that there is a risk continuum across nicotine containing products, that cigarettes are the most harmful, that the nicotine medications are plausibly the least, and where the other non-combustible products fit, but they're way less harmful. That is not a shared truth across our field. And that lack of consensus is reflected in the establishment institutions that people would look to for public health guidance. And that uncertainty conveys doubt, and which instills fear in people. And unfortunately, as you've noted from your prior webinars, it's the very people who most could benefit from switching to off of cigarettes that carry the misperceptions about relative risk most deeply. We really struggle, and we see this in other parts of our society too, sadly, but it's a deeply polarized field, an issue with people that aren't, a lot of times not even prepared to be in the same room, or they certainly visibly uncomfortable if that happens. And that's not good. And it's deeply moralized. And there's a historical and continuing basis for our moral emotions to be engaged on this topic. The challenge is, are we going to let that dominate and be the overriding energy in the discussion, and I'd like to think we can do better.
That's such a good point. And, another area where that kind of moralizing over life-saving practices happens is in drugs and harm reduction. Of course, an area that has come under a lot of attack politically and rhetorically in the past couple of years. But I do find it interesting that some of these same trusted institutions do generally, to different extents, endorse harm reduction in drug use, in illicit drug use. So like the VA with veterans, right? You've got syringe exchanges, access to Narcan, naloxone for overdose reversal, things like that. The CDC, again, this is changing like kind of in front of our eyes, but does talk about harm reduction as important in the important element in the overall response to the opioid
Mm.
overdose crisis. So, what's going on there? That one, it's sort of almost a little surprising to me that the illicit substance gets a little more traction with trusted public health leaders. Um, in terms of harm reduction being valid and necessary, and recognizing that people use substances for a reason, that quitting on a dime is not how it works in most people's lives. Like, I chew on this all the time and I don't have an answer for it. What is that bifurcation about? Why is that happening? That's for anybody.
Well, I'll jump in. Why is that happening? Uh, in 2009, Congress passed a law that gave the FDA the authority to regulate tobacco products and to make science-based decisions whether or not new products should be allowed to enter the marketplace. And the FDA would independently and objectively review science and review tobacco product applications and decide if they should be allowed to enter the market. And the determination was basically harm reduction. If new products pose a potential benefit for adult smokers who would switch to them, and those benefits to adults outweighed the risks that youth would use the products, the FDA could authorize them. So why is what you described not happening? Well, here's what happened. The largest tobacco control groups and most of the public health organizations in the United States advocated Congress for years to create a situation where Congress would give FDA that very authority that I just described. That basically the FDA would be the arbiter of science around tobacco issues and would determine whether or not lower risk products should enter the marketplace. And then since that time, those same groups have contested, have undermined, have tried to discredit many of the product authorizations that have been made. So one would think there's a scenario where the groups that create a regulatory agency then work to ensure that the American public understand what that agency's job is, why it's making decisions that it is, and implementing public health frameworks and programs and strategies to actually realize the public health benefit. But Jessica, why it's not happening is because a situation was constructed through tobacco control and public health advocacy that has then not been supported by that same community to actually realize the intended public health benefit when FDA was given that authority.
Okay. Well, then let's talk about the elephant in the room, the even bigger elephant in the room. Because some of, I think, what's driving the emotions behind this is connected to the role, generations long role of the tobacco industry in the sales of tobacco products and now of reduced risk products. So I don't think we can have this conversation without discussing that and how those past actions impact whether people trust the idea, the very concept and the evidence behind tobacco harm reduction today. So, we know that there were deceptive practices in the past to hide the fact that cigarettes cause cancer and other diseases. It casts a really long shadow on public trust and on skepticism of industry claims today, including claims that products have reduced risk or harm reduction potential for adults. So, this is maybe an obvious, everyone's just say yes or no. Does that history make it harder for public health leaders to support tobacco harm reduction for adults? Does it make it harder for people to believe, even if a trusted source was, sharing that evidence? Helen, what do you think?
I want to just before I answer that, I want to just go back to the question that you asked that Jeff's answered. And I wanted to add to that because I really, if we know who continues to smoke in the United States, right? It's people who use drugs, people who are unhoused, and people who have a mental health diagnosis. These are three of the groups that have the highest rates of smoking. Now, we live in a country that doesn't really care about those groups of people, right? There's a profound lack of empathy for these groups. There's a sense of, I believe, on the part of a lot of people in public health that we just can't reach them, right? You know, if as Jeff said, it's the same. They're working from the same script that they wrote 30 years ago. NRTs, patches and gums and medications, and acting like there isn't a whole new revolutionary generation of safer nicotine products. But more than that, these three groups are criminalized, right? I mean, if you use illicit drugs in the United States, you're a criminal. If you're unhoused, being unhoused has been criminalized, right? The Grants Pass decision a couple of years ago that said, yeah, if you're out sleeping on the street, if you're in a tent, we can arrest you and put you in jail and ticket you. And then, of course, people who have mental illness are criminalized. The Los Angeles County jail system is the largest provider of mental health services in the United States. There's something very wrong with that. And so these are the groups that have the highest rates of smoking. They're criminalized. Who wants to help them? Right? It's not the people who are smoking generations ago, the lawyers and the doctors and more white people, right? We want to help them, and they were basically able to stop. So if we have to look at who is still smoking, and is there a commitment to help these groups of people to actually have the right to health. So I wanted to add that to the mix of why I think it's so hard. The last thing I'll just say is if we look at our healthcare system and healthcare providers, they don't like these groups of people, right? I mean, I don't know how many people who have used drugs have told me, I'll be on my deathbed before I will go to the emergency room. So if we're looking to public health, if we're looking to our healthcare system to work with people to help them switch, it's very, very problematic. Not impossible, because I'm not a total pessimist, but just to reiterate, these are criminalized populations with the highest rates of smoking. Who wants to help them? Where is the empathy?
Such good points. And actually, you're reminding me of in our most recent event about tobacco harm reduction in spaces that support people that use drugs. Cindy Clay, I think it was Cindy, the head of HIPS in DC, which is a harm reduction organization, was saying, I'm sorry if it wasn't Cindy, if I'm misattributing, but was saying that like physically smelling like smoke on your clothes, on your hair, on your person, that a lot of people report stigma, being stigmatized in healthcare settings. That's like an additional layer, in addition to being unhoused, in addition to how they present and how they're seen by healthcare providers. Some, snap judgments get made right away there too, which ironically could add to, not having a ton of empathy for helping that person figure out what to do if they do want to quit smoking. Okay, can we do any other thoughts there? I don't want to stop you all unnecessarily, but uh,
Yeah,
it,
I guess in relation to your question, just real quick, um, the industry should not be trusted. The industry has a long history of deception and has been, the subject of litigation that has confirmed that. And that is exactly why the tobacco control groups wanted Congress to give FDA the authority to review tobacco products. If you look at the act, it is very clear that distrust of industry claims, and industry claims about its own science was a huge part of the reason why the FDA has regulatory authority. And then who's reminding the public that we shouldn't trust the tobacco industry? And who's not reminding the public what the FDA is doing and why it's doing it? It's those same groups. So the distrust of industry has been is inherent, is part of FDA's regulation of tobacco, and FDA makes the decision. The industry isn't able to legally sell a new product, unless the FDA reviews and decides that it's appropriate for the protection of public health for them to do that. But who's like using history as a weapon to restrict adults' access to products that could help them quit smoking and that could reduce their harm? That's an important question here. Who is weaponizing misperceptions about nicotine? Who is weaponizing the industry's past deception? Those are key questions I think that we need to ask as a society, because the reality is we have federal regulation of tobacco because the industry cannot be trusted. And the industry does not unilaterally decide it can legally introduce products to the market. That is all done through the FDA. And again, the groups that were largely responsible for leading the advocacy to give FDA that authority need to start leading responsibly. They helped create this regulatory framework, but yet they only seem to agree with the parts that they agree with, right? But they undermine and contest and attack the parts they disagree with, which is not good governance.
So I'm going to ask who I'm going to name our resident optimist, Joe. Not that you two aren't, but is a world possible in which folks can actively dislike, distrust, denigrate the businesses that will make money from selling these products, but see past that to the potential for these products to save the lives of a lot of people?
So I appreciate your tapping into my superpower here. On the Shaping Vaping podcast, which I sometimes do with AVM's Jim McCarthy, we had David Sweener on as a guest, and I said, "Oh, I suffer from optimism bias." He's like, "Joe, I've known you for 30 years. It's optimism psychosis. That's your problem." Um, so I we have so much work to do. It is stunning to me. I was just reflecting. We are almost at the 25-year point of Lynn Kozlowski and colleagues publishing a commentary in the journal Tobacco Control titled "Use Medicinal Nicotine Now for Harm Reduction: The Risk-Use Equilibrium Continuum." Anyway, I'll put the link in the thing. The point is 25 years that we've had thoughtful, unconflicted people saying, here's an idea. Why don't we use less toxic products to help people suffer less consequences of harm? 25 years. So we are not breaking records in terms of speed of translating scientific insight into practice and policy that will help people. But where I think we will make progress is the field of what used to be called smoking control used to never have to confront and resolve trade-offs because it was a very absolutist type situation. Smoking was very harmful. It was addictive. It was enriching cigarette companies that were defying and delaying scientific progress and health. And everything you did, maybe, raising taxes, banning where people could smoke, they all reduced smoking and they advanced separate goals all at the same time. Maybe not all to the same extent, but you never had to play one off against each other. Oh, this will only help prevent young people from starting. It won't have any benefit on helping current adult people who smoke to stop. But now we face that trade-off with consumer appealing, much less harmful products. There are trade-offs. And the field, I would argue this is part of it, needs to build back up the muscles of we can identify these, we can discuss them, and we can come up with ways to optimize the benefits and minimize the risks. And to Jeff's point that he makes very fairly, that's why there was established a regulatory agency which has resources, authorities, and expertise to help make some of those decisions. And the challenge will be is, will the trusted civil society community say, you know what? this is a way that's going to greatly improve health. Will it look exactly like my advocacy dreams? No. Will it still lead us to be a much more healthful country for the rest of time? Yes, sign me up. How's
Helen,
that? Optimism,
that's good.
psychosis, validated.
I,
Yeah.
never stop. Never stop being you. Helen, okay, my question for you within this, and of course, say whatever else you want as well, but you are very close to the folks you're talking about, right? You are working with people, talking to people, like, you are with the folks that we, in our whatever language say have lived experience. So, do you see this in drugs and harm reduction where you do a ton of work as well? Do you see this company made money by fueling the opioid crisis, so therefore, if they have something good to offer medicinally, we shouldn't trust that thing?
Mhm.
Do people say that? Is that like a trend on the
I,
drugs and
I
harm reduction side?
I have not heard that. No, I haven't heard that. What I wanted to, I'll come back to that. I wanted to just build on what Joe said. There's lots of states that have no trouble taking master settlement agreement money. So
Mm.
there's lots of entities out there that don't have a problem taking that money. It's billions of dollars. So there's that. What I wanted to say was I think it's interesting. So the shadow of big tobacco and that those entities having their products authorized, it's interesting because the company Glass just had their two flavored vapes authorized by the FDA, and they're a Los Angeles-based company that has never had any affiliation with the tobacco industry, and the tobacco control people ganged up on Glass as if they were, and were saying, just conflating, saying this is predatory tobacco industry. Well, wait a minute, this is Glass. It's a small company that has nothing to do with the tobacco industry, and we saw that years ago with Juul. When Juul came onto the market, for years they had no affiliation with the tobacco industry. At one point they did, they don't anymore. So my sense is that it doesn't matter what who the company is. It's about nicotine. So they've kind of shifted the goalpost. Now it's about nicotine, and whoever it is, they're trying to get young people addicted on nicotine for life. They want a new customer base. This is the story that they're spinning. So it doesn't matter if a company has nothing to do with the tobacco industry. They're going to get dunked on by the tobacco control industry. And the tragedy for me, this is what I always go back to, is they drove out of business hundreds, if not thousands, of small vape shops, mom and pop, often owned by people who used to smoke, and said, I'm going to help my fellow smokers quit. They drove them out of business. And those essentially acted as smoking cessation clinics in the community, right? And they had the trust of neighborhoods where they can talk about the products, they can help, and they've been wiped out. And so here we are, right? All of the solutions that we have proposed, because I'm concerned about corporate capture. I don't like that. I don't like that the tobacco industry, the majority of the vapes that are authorized are made by tobacco companies. Now, they can have that, but why can't smaller companies and the mom and pop places? I want them to be able to offer these products as well. So I'm concerned about corporate capture, and we're seeing it everywhere. We're seeing it in cannabis. We're seeing it in psychedelics, right? Who's going to control access? So I'll just leave it there for people to chew on that.
So I'm just going to jump into the Q&A for a second. And we've got a question or comment about, I think, Helen, you were talking about your comment that you're not seeing empathy for these very marginalized folks, people who use drugs. So I'm just going to read the comment and just let you respond to that because I won't editorialize. So the comment is, in the public health communities, there isn't empathy. Don't like these people. Are you serious? So can you respond to that? Is that, what did you mean by that statement? Put it that way.
Well, what I mean by that is you don't have empathy and concern for people who smoke if you keep offering them NRTs that don't work. And then you end up blaming them for not quitting smoking. Uh, the fact that, I'm here in New York City, and our public health department, uh, you said earlier, Jessica, on the one hand, they embrace harm reduction for some things, but not for the other things. So here in New York City, they're all over naloxone. They support overdose prevention sites, places where people go and use illicit drugs, but they won't support safer nicotine products. And they have a campaign, drop the vape, not pick up the vape, which I think that should be the campaign. Adults, pick up the vape. It was geared towards teens, but the teens have already dropped the vape. Jeff gave the statistics. So you don't have empathy and concern for people who smoke if you are not directing them to use safer nicotine products. You're not doing your job. You're not listening to the evidence. And the evidence is there. Cochrane
Yeah.
review. I rest my case.
I think we have a highly informed audience here, but could one of you give a very quick, very brief overview of the Cochrane Review and what we know from it, what it is, why you believe it's trustworthy, and what it tells us?
You want to do it, Jeff?
Why don't you do that, Joe, and then I've got a follow-up.
Okay. And I'll try to drop into the comment to build on Helen's point. And I had forgotten it until now, but Helen, you might recall the New York City Health Department had the Play Jour campaign, like promoting safe sex practices. And I'm like, imagine what could be possible if they embrace the continuum of risk as a tool to help drive down smoking and
Yes.
improve health. So I'll try. Hopefully, I'm not just flooding people with unsolicited, unsavory, or maybe say some people may like it. Looking at some of the attendees is possible. Anyway, Cochrane collaboration is a long-standing international effort to bring synthesis to evidence to inform the practice of medicine. And they do systematic reviews to help clinicians make good choices to best help their patients and preserve scarce health resources. There's been a Cochrane tobacco addiction group for like 30 years. They have, if you Google Cochrane tobacco addiction group, you will see all of their reviews. They cover all sorts of interventions that do prevention, that do cessation. They have one on e-cigarettes for smoking cessation. They've had it for 12 years now. It's a living review, so they do searches every month and they do updates about once a year. And it basically is the most highly regarded, respected, relied upon synthesis of evidence to inform medical practice. And their most recent review, among their main conclusions, are that nicotine-containing e-cigarettes provide more success to people trying to quit smoking than NRT products. And they have high certainty evidence that that is true, that more study is unlikely to change that. So for the people who say we really need to look at the evidence and either don't cite Cochrane or they cite Cochrane and say, but there are these other things that agree with me. It's like, no, you really have to come up with the reason to disagree with Cochrane, and it can't just be, well, industry likes Cochrane. A consultant for Juul is saying praiseworthy things about Cochrane. That's something to bear in mind. It shouldn't be dispositive in terms of how you judge it.
Yeah.
So, yeah.
Oh, sorry. I would just build on that or expand it. Like maybe take the Cochrane example and boil it down into like public health strategy. So, knowledge claims like that, like the Cochrane review, they review a lot of studies, a lot of evidence, they make conclusions. But we've got to be cautious about accepting any knowledge claim as uncontested, unquestioned truth, right? So consider the following two groups of conclusions. One comes from Public Health England. Public Health England reviews evidence across a broad range of studies, synthesizes that evidence down, makes conclusions, and gives recommendations that inform tobacco control in England. And then the Surgeon General's report. So the US Surgeon General's reports on smoking and health do the same thing for the US. They review evidence, they make recommendations, they inform tobacco control strategies. Here's Public Health England. Recent studies support findings of the Cochrane Review that e-cigarettes can help people quit smoking. There's also evidence that e-cigarettes can encourage quitting even among those not intending to quit or rejecting other support. More research is needed in this area. It is not known whether e-cigarette products are more or less effective than licensed stop smoking medications, but they are much more popular, thereby providing an opportunity to expand the number of smokers stopping successfully. Okay, that was Public Health England. Here's the US. A few years later, after the evidence was even stronger around cessation, there is inadequate evidence to conclude that e-cigarettes increase smoking cessation. Well-controlled, randomized clinical trials and rigorous large-scale observational studies with long-term follow-ups will be critical to better understand the impact of e-cigarettes on cessation. Nevertheless, the potential benefits of e-cigarettes for cessation among adult smokers cannot come at the expense of the use of these products by youth. Okay, so there you go. You take those two. They're based on the same evidence. It's based on Cochrane Review and similar studies. And in one, you're like, okay, these are used by a lot of people. There's evidence that they're successful. We need to build strategy around that concept. And the other one is like, we need to have such a rigorous scientific review process that we may never know. Like, we may never know if they're effective, but that doesn't really matter because at the end of the day, all that really matters is we've got to protect kids from these. It's the same evidence that's used to translate into different strategies based on who is considered important. So the person who asked the empathy question, where's greater empathy for adults who smoke cigarettes and want to quit in the United States? Because there can be greater empathy shown toward them. Regardless of, there's zero empathy, but there can be more. That's, I think, what this call is all about.
You are the segue king here, Jeff, because I'm hoping that we can then take what we've been talking about. We could do this for another couple hours for sure. And we'll hope to get to some of the additional questions here too. But to do a little role play break, like this is a mess. I'm trying to imagine, I think of one of my best friends from college who's an internal medicine doc. She's practices in Baltimore. So she sees all kinds of folks in her practice. I would love for her to be my doctor. She's incredible, very empathetic, as many people in healthcare and in public health are, very caring. She's got 2 kids. She's up till 1 a.m. charting. She cares about her patients. She is super busy. So, like, what is her, and I'm not calling her out specifically, but someone like her, like a busy doctor in a practice, I try to imagine her parsing all of this. She's hearing her medical association that she trusts say one thing. She's seeing news headlines say another thing. I doubt she's reading the Cochrane Review. She is swamped with her patient care. Like, what is all of this swirling and inability to, it's a great example of looking at the same thing and portraying it as, Public Health England versus Surgeon General in a very different tone. What's a doctor to do, for example, or what's a harm reduction specialist at the VA who serves veterans to do, where veterans smoke at very high rates, and they've got all this support for harm reduction in drugs, but nothing, silence from the VA at best, and then some remaining communications that say that vaping is bad and etc. Or like a lawmaker. What's a lawmaker to do that is not an expert in this area, or their staffer more likely, and has like 8 issues on their plate and they're 25 years old and they're trying to manage all of it for the boss? Like, can you talk through have you seen how that works in real life, or what there's to be done about this kind of information morass? Like, what is a doctor likely to do in the face of all of this, for example?
Well, I'll jump in. That was a very powerful summary of a very polluted information environment. And I think a conclusion from this is we just need to remember that this is a topic where for some of us, it's our main focus. For a lot of us, it's a big focus. We've been able to interact with thoughtful other experts who can bring insight and knowledge and help us pierce through this. We gotta have grace for the people who don't have that benefit and can't, like, it's a lot to expect of anyone out in the world for whom this is not their focus to come around to this. So I think that's just a reminder of there's a reason why it's taken 25 years since Lynn Kozlowski et al. Published their thing. Like, it's a lot to be done. Because if they turn to their usual sources of trusted information, they're not going to hear what Jeff just highlighted, or they're going to hear, well, Surgeon General report, USPSTF, insufficient evidence, really shouldn't be doing it. That's what they're going to get, and that'll be enough to shut it down and move on. And sorry, I got 17 other things to have to worry about.
Yeah, this is an interesting question. I'm just thinking back, how did all these doctors learn about OxyContin and learn how to prescribe it? They're so busy. They don't have time to read the literature. So there's an army of pharmaceutical reps, right, that they make time for to learn about OxyContin and why they should prescribe it for everything. I'm being a little facetious here about doctors, but they clearly do get education. We're at a deficit in the sense that we don't have an army of safer nicotine product reps providing lunch for physicians. I want to throw into the mix physician associates and nurse practitioners, because they are a very important part of our healthcare infrastructure. They provide care to millions of people. And so we don't have that. So then where do they get their information about safer nicotine products and what nicotine actually does, right? And I'm sure many people here are aware of the study that showed that a majority of physicians believe that nicotine caused cancer. So we're not doing a good job as far as that goes. I know there are people who are working on this, though. Here's the optimist in me. There's a number of projects that are actually trying to educate healthcare providers around nicotine. So I think, as Joe said, it's a polluted environment, and I look to, because I work with people who are using drugs and are unhoused and have mental health concerns, and all that intersection. And so in many organizations that serve these groups of folks, they do have healthcare providers. They're writing prescriptions for buprenorphine. They're treating Hep C. And this is a group of providers that I have targeted, other people have targeted, and it's really it's going right to where people are at, right? So really targeting that group of healthcare providers who are working directly with people who are unhoused, right? Like I said, I was recently in the Bay Area, and they have street medicine. So they have physicians, nurse practitioners going out onto the street. And so I look to those places and spaces that we can work with health providers who in some ways they're already on board for harm reduction. And some of them have made the leap to tobacco harm reduction.
Yeah, and I think I have faith in the broader public health community. Like, tobacco control is a field within a broader public health field domain. I think, for public health, it would be great if we reestablish as a priority ending smoking, right? That used to be very, very clear. While there's a lot of controversy and confusion and differences of opinion around the relative risks of new products, there's no disagreement that cigarettes are uniquely lethal. They're a deadly, outdated, unnecessary consumer product that our society allows to continue being sold. So let's end that and trust regulatory science. I think if the broader public health community would look to the Cochrane Review, would look to the FDA's regulatory conclusions and statements, would look to the tobacco regulatory scientists that are funded by the FDA to inform it. Like there are truths out there. You need to look for them, but the broader public health community wouldn't just accept like, oh yeah, what this group says has got to be true because they've historically led tobacco control in the United States. Well, maybe take a minute, look, consider, and then the third thing, the third thing that the public health needs to do is engage people with lived experience, engage people who smoke, engage people who've struggled with nicotine addiction, who've tried to quit, engage with people who've used newer products to quit, learn from the people who are affected. And I think if the broader public health community would do that, reestablish ending smoking as a priority, trust in regulatory science, and engage people with lived experience, we'd have a different approach here in relative short order. Because honestly, the current approach is not as empathetic as it needs to be. All due respect to whoever posed that question, but no, we've got a lot of issues on that front.
So I'm going to move us into Q&A, but it's very connected. Of course, these are in response to our conversation. So I'm going Helen primarily for this one. We've got an anonymous attendee asking the following. The tobacco industry has co-opted harm reduction and behavioral health messaging in their branding and marketing. Does this not harm the reputation of harm reduction in public health as a strategy when we let a notoriously manipulative industry use our own words against us? Why not call out big tobacco for stealing the spotlight from harm reduction champions? Your thoughts, Helen?
Well, I want to come back on the last thing that Jeff said, and that is public health have spent decades stigmatizing people who smoke, actually encouraging hatred towards people who smoke. If you look at, I did a presentation once where I showed a bunch of images that come from public health, and calling people who smoke dumb. Their head is an ashtray and they're putting out a cigarette. Using coffins, you're going to die. There was a photo campaign here in New York years ago of people who had been trached because they got cancer from smoking. A woman her fingers had been, part of them had been amputated. These gruesome photos and public service announcements of people who smoke, basically saying, I did this to myself. Right, this victim, this horrific victim blaming that people who smoke internalize. So, public health has spent decades demonizing and stigmatizing people who smoke, and so I want them to stop doing that, right? And as Jeff said, people with lived experience smoking, they are part of the solution, and many of them are using these safer nicotine products, and public health can learn from them. So harm reduction belongs to the world. Anybody can use harm reduction. There's no patent on it as far as I know. And it is a very strange reality. It's the kind of upside down world, clown crazy world that we live in, that the tobacco industry is actually for harm reduction. They want people to switch to safer nicotine products. They really do. I don't know now, what are their motives? Because they can continue to make money, right? It's all about nicotine, right? It's all about nicotine. It's all about the delivery device. You can get it through a cigarette, you can get it through a vape, you can get it through a pouch. And so the industry will continue to make money as people switch. And they're for that harm reduction. So there's that. And the other side of that is public health is not embracing tobacco harm reduction. They should be leading it, right? They should be leading tobacco harm reduction, but they're not. And we've got to be honest, public health, at least in the United States, has often been behind the curve when it comes to harm reduction interventions. I'm going to go back to the AIDS crisis. It wasn't public health that said we need sterile syringes, we need to be handing them out to people, we need to make them free because we have to stop the spread of HIV. It wasn't public health. It was drug users, people who were injecting drugs. It was the AIDS Coalition to Unleash Power. It was groups of people with lived experience who fought that. And then public health eventually joined, right? But you often have to bring them into the conversation. They're screaming and they're kicking their feet. And so they're not for tobacco harm reduction, but the tobacco industry is. And so the other just quick example is, flavored vapes. I mean, who would have ever thought that Trump would get involved and overrule Macari and say, you will approve the flavored vapes, right? You would have thought the FDA, as a public health organization, they looked at the science, the evidence is all there, but no. So it took an authoritarian right-wing monster, Donald Trump, to say you will approve flavored vapes. So this is the upside down world we live in. And I don't have an explanation for all of it.
Can I just say my worry, regardless of party, regardless of who sits in the White House, I do worry that type of move further erodes public trust in the decision-making process. Was it politically motivated? Was it this or was it that? Helpful in that people who will be more drawn, adults, to a flavored vape to quit smoking, helpful in their access to a regulated product that they know what's in it and it's not sort of completely Wild West out there. And I think long-term, possibly unhelpful in the polluted information environment, as you say, Joe, because I think we have we're running out of time, but one of the questions saying, like, I don't really trust that what the FDA and CDC does with the current people at the helm. So, yeah,
It's
sort of
complicated.
it's complicated. Shall I look at, we got a couple, it's too many to get through, but, we've got, someone asking a question around a July 2026 Karolinska Institute clinical study around nicotine pouches and gum recession and oral lesions. And so asking whether you folks agree that the conversation around tobacco harm reduction should include oral health and impacts on oral health.
I mean, absolutely. I think you want to understand the potential harms, the potential risks and harms of any new product. I'm not familiar with that study, but what I would say, so again, the FDA regulates these products. It makes decisions whether or not to allow products to enter the market. For products that do enter the market, it uses post-market surveillance, and it continues to gather evidence regarding any products that it has authorized. And it is within FDA's authority to remove a product from the market, to basically revoke the marketing granted order that a company receives. So for emerging evidence, again, that's where supporting the regulatory framework that tobacco control was smart enough to put in place back in 2009 helps us with the very situation that was outlined in that study. If there are dangerous products, if there's sufficient evidence, the FDA pulls other products off the market, weight loss drugs, medications, food products, etc. Tobacco should be absolutely no different.
Read a couple comments. Laura Guzman, who's the head of National Harm Reduction Coalition, just notes, not really a question, but NHRC, long-time harm reduction in drug use and in sexual behavior is actually embracing tobacco harm reduction to make sure people who use drugs do not die from smoking combustible tobacco. So thanks for that, Laura. We've got a couple people saying, sort of defending depicting smoking as a negative and deadly action as a way to prevent youth initiation. Someone's talking about that under Juul, and youth in a younger generation are not initiating vaping because of this kind of messaging. So curious whether, maybe you've all said all you need to say about, the stigmatization of smoking. I see you nodding.
Yeah, I would just say, folks, go ahead and Google Scholar smoking stigma and Bayer, Bayer, and Bell, Bell. You'll see some sociological accounts of the impact that stigmatization has. helpful from a population standpoint in terms of the outcomes that the folks are familiar with, very damaging to the individuals who experience that, especially those who cannot comply with society's normative expectation that they quit. And then they're continued to be stigmatized. They experience incredibly regressive taxation and, and the negative health effects of cigarette smoking. So if you have questions about stigma, Google it. You'll find some really powerful studies that are 2 decades old.
Thank you, Jeff. We're at the top of the hour. I can't remember now, but I think one of you had to go right away. So if one of you has to go, or any, go. If any of you is willing to stick around, we've got 30 attendees still hanging in with us, so we could talk a little longer, but feel free to unceremoniously drop off our wonderful panelists if you need to. I want to be respectful of your time, and thank you so much for doing this. I'll read another. We've got someone from a harm reduction program in Palm Springs, California. The program offers nicotine replacement therapy in the form of 3 milligram and 4 milligram Nicorette lozenges free to any participants who want or need it. Is this a common practice among harm reduction programs in general? Sorry, they corrected 2 milligram and 4 milligram. Most of their participants are unhoused. Helen, have you seen that out there in the world? And have you seen any, how do those NRT products work for folks? Is that,
We
are you
don't.
seeing those help folks? They don't, is that what you said?
They're not. I mean, the rate of success with these old NRT products, people have to get state of the art. Come on. Vaping is great. People love vaping. People don't love patches and they don't love gums. The gums taste horrible, even though they're flavored. Okay. There's lots of fruit flavored gum, and the patches. And so what every program needs to offer people who smoke are vapes. Go to the FDA's authorized list of vapes and buy a bunch of them and give them to your participants. You could also give them Zyn, or other nicotine pouches. It's purely nicotine. Put it in between your cheek and gum. That is evidence-based. Vapes and nicotine pouches, that is evidence-based. That's what I strongly recommend you do. And then you're going to be so happy and you'll have a sense of incredible satisfaction when you watch folks make that transition and leave the cigarettes behind. You'll be so happy.
So allow me to model constructive disagreement with Helen. So agree with Helen that particularly folks in these situations deserve help that they find appealing, attractive, and can use and get the results that they want. Completely agree. I can imagine that some settings, there may be either management, administration, healthcare professional, they're just not going to be up for that. And what I would say, as someone who consulted on Nicorette and Nicoderm for 20 years, is that while they're not state of the art and they're not modern, there's a lot of utility that can come from them. And there's a lot of overlapping issues. A lot of people, especially with the oral forms like gum and lozenge, they way underuse. They only use 4 or 5 pieces a day when they need to be using more like 9 to 15 to 20 pieces a day. One of the reasons why they do that, and this may sound familiar with people who try to encourage people who smoke to switch to vaping, is that they're worried that it gets them too much nicotine. And is nicotine what I'm supposed to be running away from? So my point is, maybe it's a baby in the bathwater, whatever. If what the tool that you have is NRT, yes, you can do better, but you can do better with that too. And some of that is reassuring about the safety and toxicity profile of the product and encouraging people to use enough until they're comfortable and not missing a cigarette.
We've got a
Was that
thank you,
constructive
Joe,
disagreement?
from someone who's helped 30,000 tobacco users with FDA approved meds. So you've got a thank you there for mentioning this. I mean, that's kind of, I think it is something that gets lost in the conversation around people who are supportive of tobacco harm reduction. And I will always admit that I kind of had to be dragged kicking and screaming to it because I was very skeptical. But that's not to the exclusion of these other things if they work for people. I like You can hear my horrible allergies. Some medicines work for me, and then one wasn't working. Now I have an inhaler. It's like, because of your life experiences, how you experience whatever, how you experience smoking in this case. Is it something that you more do out of boredom or loneliness or stress relief, or everyone's got their own journey on these things, right? So, I just want to kind of head off at the path that, anyone's saying that tobacco harm reduction is the only way to quit smoking. It is just an additional way that seems to be especially important for these left behind, left out folks where smoking is now concentrated. Like I in my little suburb don't see people smoking around me, my kind of little middle class town. Um, okay, people are still hanging in with us. So if y'all are willing, we've got someone asking Matthew Barrs, MS, the concept of reduction to cessation is not dissimilar to the concept of harm reduction. Seems like that is missed. So I'm not sure if that's asking like, is harm reduction only good as an intermediate step to then stopping using nicotine altogether? I'm not positive there,
I
but
think
curious your thoughts.
I think where Matt may be going, and this is so and this could be another angle if we want to talk about, but as touched on, is that this dissent and debate is has global themes too, but there are countries, peer nations that have come to much more of a consensus that the continuum of risk is real and it should be used to help drive down smoking. Like New Zealand, the UK, kind of Sweden backing into it, Japan by accident, but it's still mostly happening. But in England and in lots of other countries, the box of nicotine medication has a much expanded array of different ways to use it. In the US, it's essentially quit abruptly, stop smoking, start using the med. And there's now, since 2013, a little more flexibility if you're still smoking for a little while, like, okay, that's fine. But in the UK and much of the rest of the world, you can keep smoking while you start using the NRT and slowly reduce your smoking while you increase your NRT. You can use the NRT in times and places where you can't smoke to reduce withdrawal that you might experience then. You can use the NRT for a long time to stay off smoking as a specific labeled indication on the product. And I think I'm channeling Matt, but there you want to be able to offer people a range of options. And part of that is different products, but part of that is different ways to use existing products. If people knew that, hey, you could use that Nicorette lozenge while you cut down your smoking. Oh, isn't that dangerous? No, it's not dangerous. We know a ton about this. Just make sure you're using enough lozenges and increase them over time. Like there's ways to do that. And that may be appealing to certain people who smoke.
Mhm. Can I just say, I have never seen this many people hang in 8 minutes after the official end of the event.
Well,
So
that's Helen. That's
y'all
Helen.
must be,
People will stay around to
Well,
hear
it's
what
Three
Helen has to
Stooges.
say.
It's the Three
that's
Stooges, I
fair.
think. No,
I
I
just
think
have a quick
that
from the person at the harm reduction in California. She just notes, and I think this is interesting from a pragmatic standpoint. She says, "Thank you. We get the Nicorette donated, but we are cost restricted to purchase vapes. If and when we can get those modern products donated, we will certainly switch." So, I mean, that's just real. That's just a real thing that maybe there are restrictions. I don't know if this is what she's saying, but on grants saying you can't use it to, purchase vapes or, tobacco harm reduction products, or maybe it's just there's not enough money and Nicorette is donated. I can only imagine the absolute maelstrom if a maker of vapes donated them. That would not fly, I'm guessing. But yeah, the people trying to do this work on the ground, and we heard this from Kevin Garcia in our last event, who runs a syringe services program in Colorado, was like, we don't have the budget for it. I don't even have the funding to be able to programmatically like weave that in a consistent way, that education to our participants. So there's a lot of just cost barriers here too.
Yeah, we should not be presenting this to people as use these safer nicotine products to reduce and then stop, right? That is the wrong way to present it to people. And for me, that's not harm reduction. It's what the person wants. That's what does that person who smokes, what do they want? And then I think it's also important to have a conversation with people about the benefits of nicotine, because we don't talk about that enough. So I know that a lot of people that I have worked with over the years, they get real benefits from using nicotine. And so we would have a conversation about that. And I would say, you don't have to stop. You're using a safer nicotine product. You've dramatically dropped your risk for all kinds of health problems. If you want to maintain on nicotine, I don't see a problem with that. There's no problem with that for real harm reductionists. But there's a group of people who they're taking a middle position. Well, you can use it, but then the end goal, and I'm telling you what the end goal is, has to be cessation. No, don't say that. You shouldn't be saying that, right? And the other thing I think of why programs have to offer this, even though I'll take a little bit of what Joe said, maybe they didn't try those old broke ass NRTs well enough. But the ritual of vaping, the ritual of smoking is so powerful, and the gum and the patch cannot approximate. Let's just get real here, right? And so we have to remember that the ritual is so important for so many people. And let's talk about the benefits of continuing nicotine use for some people. You always have the choice to taper off, right? You can always do that.
Let me jump in real quick because the cost aspect is really important here. And the cost, I directed the New York State Bureau of Tobacco Control. We had a $20 million budget for cessation. We had statewide network. I directed the cessation network for the Ohio Tobacco Prevention Foundation. The limit is always resource-based. Like, you can never provide enough free NRT for people who would probably want to use it and could use it. There's not enough, the reimbursement for physicians to treat their patients for tobacco dependence is too low for many of them to do so. The cost, out of pocket cost for someone to purchase NRT compared to just the next pack of cigarettes might be a barrier. Plus, you can't buy NRT everywhere where you can buy cigarettes, right? You don't walk into a convenience store and see a whole bunch of NRT. So the other aspect of harm reduction that's really important here, that public health needs to do a better job, is people who smoke, most of whom want to quit, half of whom are going to try to quit. When they go into a store to buy their next pack of cigarettes, they should see near the cigarettes, an alternative that public health has told them is lower risk. It should be priced so that the price is lower relative to the price of cigarettes, so that our society is equipping people with knowledge that they need to make a decision. We're creating a price structure that motivates them to make a healthier decision. And we're allowing people to be harm reductionists when they're buying their next pack of cigarettes and they decide instead they're going to buy pouches, or they're going to buy a vape, or they're going to buy a heated tobacco product, whatever the case may be. That's the other thing. We don't need to top down this. We just need to create an environment in which people who already want to make a behavior change are given resources that can help them do so and can help lower their risks. If they eventually quit using nicotine entirely, that's great. But if we can get them to quit smoking, we know that that is beneficial, and we know that that's what most of them want to do. So why not get on board with what 25 million people in America want to do?
Very succinct. Equip people with knowledge, a motivating price structure, and access the same, equal to accessing the deadliest product out there.
Absolutely.
This is a decent place to wrap up, given that we're 14 minutes past the end. Unless Joe or Helen, you've got things to add. We just love talking to y'all. Love the productive disagreement. We had someone in the Q&A just chiming in to say, I hung in all this time because I'm tired of losing loved ones, and said thank you for this. So I think to me, that's always the North Star, is like, is this stuff uncomfortable? Yes. Did I ever know I would be having these conversations? No. But people's loved ones, like that, this is what matters. This is why we should be showing up every day. And I believe, I'm on Team Joe, no cynicism allowed, that everyone in this space has that motivation. I want to believe that, but it's the how now. It's the recognizing the reality of people's lives and going, what do we want more? Do we want to feel righteous Or do we want to be effective? Then I think we have to choose.